Hello everybody. Today we are going to discuss about neutropenic sepsis. So we have this 57-year-old male patient who was a known case of aplastic anemia on treatment. There was a history of CVA with the right hemiparesis. He was also a known case of rheumatoid arthritis, but he was not on any medication. And there was also a history of the abdominal cocks for this patient, and he was admitted to the outside local hospital from 28th of December 2023 to 4th of January 2024 with the chief complaints of fever on and off since 2 days, bleeding gums, swelling of the right cheeks, generalized body weakness. So when he was evaluated outside, his patient's HB was 8, platelets were 35,000. So he received 1 point PRBC, 6 point ST. He was started on the antibiotics, and the details of the antibiotics was not mentioned, but patient was not improved there. That's why he referred here for the further management. So when we received this patient in ICU, his pulse rate was 116, blood pressure was 100 by 60. He was requiring NORAD of 2 ml per hour. RR was 18 and SpO2 was 100 on the room air. And on systemic examination, CVS S1 S2 present, RS bilaterally crepes were there. Per abdomen, it was soft, and the CNS wise, patient was conscious, fully oriented. So we have sent all the blood investigation because patient was presented with the fever, including blood culture, and the urine culture was also sent. And we have ordered radiological investigations like chest X-ray. So ABG of this patient was taken and the pH was 7.4, PCO2 28, BICAR was 21. And chest X-ray was suggestive of consolidation on the upper part of the right. So this was the blood investigation of the patient. As we can see, patient's HB was 8. WBC count was just 180 and platelets were just 4,000. So clearly this patient was in neutropenic sepsis, considering the background history of the patient and considering his history of aplastic anemia, history of fever, plus by looking at this WBC count, we interfered that the patient is definitely in the septic shock and he has the neutropenic sepsis. So we have calculated the mass score, which came out to be 16. So we categorize this patient into the high risk category. And we have started him on the antibiotics. Initially, we started with the monoself, SZ, and other supportive management. So patient's condition after that started deteriorating. He was complaining of breathing difficulty. We put him on NIV support. Gradually, the patient also became hypotensive and his NORAD requirements were increasing. So antibiotics were escalated to injection meropenem, targocid, and injection polymyxin was also started. And we have also given the empirical fungal coverage in the form of Iraxis. So the patient's septic shock was worsening. Eventually, this patient had cardiac arrest. He could not be revived despite all resuscitative efforts. The final diagnosis of this patient was neutropenic sepsis with septic shock. So we'll see what is this neutropenic sepsis and how to manage. So febrile neutropenia is defined as oral temperature more than 38.3 degrees Celsius or two consecutive reading of more than 38 degrees Celsius for 2 hours and absolute neutrophil count more or less than 500 or expected to fall below 500. Now, incidence, morbidity, mortality, and microorganisms. So, despite major advances in the prevention and treatment, febrile neutropenia is the one of the most frequent and serious complication of cancer chemotherapy. And it is a major cause of morbidity, healthcare resource use, and compromised treatment efficacy, resulting from the delays and dose reduction of chemotherapy. Most standard dose of chemotherapy regimens are associated with the 6 to 8 days of neutropenia, and febrile neutropenia is observed in 8 cases per 1,000 patients receiving cancer chemotherapy. Febrile neutropenia is responsible for considerable morbidity as 20 to 30% of patients present complications that require in-hospital management with overall in-hospital mortality of 10%. There is clear relationship between the severity of neutropenia and the intensity of chemotherapy, and it has been shown that several factors other than chemotherapy itself are responsible for increasing risk of neutropenia and its complication. So what are these other factors? So age plays major role, with older patient having higher risk of febrile neutropenia following chemotherapy with worsened morbidity and mortality rates. Then advanced disease, history of previous febrile neutropenia. Then if the patient is not on any antibiotic prophylaxis or granulocyte colony stimulating factor use, if mucositis is there, poor performance status, or cardiovascular disease and presence of comorbidities. So the prognosis is worse in patients with proven bacteremia, with mortality rates of 80% in gram negative and 5% in gram positive bacteremia, and the presence of focal site of presumed infection, that is pneumonia, abscess, cellulitis, also makes the outcome worse. So the mortality varies according to the Multinational Association of Supportive Care in Cancer Prognostic Index, that is MAS score. So if the MAS score is more than or equal to 21, then the mortality is less than 5%. And but the possibility is as high as 40% if the MAS score is less than 50. Now we'll see how management of febrile neutropenia regarding patients' education and local policies. So success in febrile neutropenia management requires the prompt recognition of and reaction to the potential infection. It is very vital to educate outpatient to monitor their symptoms, including body temperature, and to provide clear written instruction on when and how to contact the appropriate services in event of concern. Now, for emergency department, some patient may present with febrile neutropenia at emergency department, and in this situation, clear protocol must be there in place to manage this patient appropriately. So the first administration of therapy should be given in hospital within first hour from the admission of the hospital with febrile neutropenia. Any delay in antibiotic administration has been associated with significant prolongation of hospital stay and increased mortality. Now, initial assessment and investigation. So, a detailed history should be taken, including nature of chemotherapy, prior prophylactic antibiotics, concomitant steroid use, recent surgical procedures, and the presence of allergies. It is important to check the clinical record for the past positive microbiology, in particular previous presence of antimicrobial resistance organism or bacteria. So an initial assessment of circulatory and respiratory function with vigorous resuscitation whenever necessary. So signs and symptoms of infection in neutropenic patient can be minimal, particularly in those receiving corticosteroid or in elderly patient who often may present with the confusional state. Now, the careful examination of following systems are required, like respiratory system, gastrointestinal tract, skin, perianal region, genitourinary discharge, oropharynx, central nervous system, knowledge of the previous positive microbiological results by checking clinical records, and also note the presence of indwelling catheters. Now, the vigilance is required in patients with at risk of febrile neutropenia who presents unwell, who are hypotensive, and who are low grade temperature or with the low grade temperature or earthquake. So, routine investigations are required in the form of urgent blood testing to assess bone marrow, renal liver function test, coagulation screening, and C-reactive protein. Blood cultures, including culture from the indwelling IV catheters, urine analysis culture, sputum microscopy and culture, stool microscopy, skin lesions, and chest radiography. Now, the further investigations are required in the form of HRCT and bronchoalveolar lavage. Now, after investigating everything, we need to calculate the outcome assessment score so that we can prognosticate the patient and we can counsel the patient. So how to prognosticate the patient, how to prognosticate this patient? So on the basis of MAS score, we can do that. So what is MAS score? So it involves the components like burden of illness. If patient has no symptoms or mild symptoms, then the score is 5. If the patient has moderate symptom, then the score is 3. If the patient presents to us with severe symptom, then the score is 0. If the patient is not hypotensive, that is systolic blood pressure is more than 90, then the score is 5. If there is no history of COPD, then 4 score. If there is a presence of solid tumor, lymphoma, and with previous fungal infection, then the 4 score. No dehydration, 3 score. Outpatient status, 3 score. And if the age is less than 60 years, then the 2 score. And if this total mass score is more than or equal to 21, then the patient is at low risk of the complication. But for our patient, this mass score was 16, and the patient was in the high risk. So we'll first see how to manage low risk patient. So we can start with the oral therapy for those patients who are hemodynamically stable, who do not have any acute leukemia or any evidence of organ failure, who do not have pneumonia and indwelling venous catheter or any soft tissue infection. Then we can start therapy in the form of single agent quinolones like moxifloxacin, or we can also start the combination therapy with quinolones and with amoxicillin plus clownic acid. But the latter are preferred in the given the rise of gram-positive or febrile neutropenic episode. Oral quinolone therapy should not be used in patients who have taken quinolone as an antimicrobial prophylaxis. So in afebrile patient after 48 hours on IV therapy, we can safely shift to the oral therapy. Some low risk patient may be treated with outpatient parenteral regimen. Now regarding outpatient and early discharge policy, the possibility of exclusive oral outpatient management for low risk of febrile neutropenia cases has become increasingly appealing on the basis of patient convenience, economy, and reduction in the incidence of nosocomial infection. There is also evidence to support early discharge policy in the low risk cases once they have become clinically stable and symptomatically better. Now, how to deal with this high risk patient? So, patients with febrile neutropenia who are at high risk are assessed by the MAS criteria, that is total score of less than 21. Then we should admit this patient and we should start with the broad spectrum and IV antibiotic since the risk of bacterial sepsis is very high. Now, what is the choice of IV antimicrobials in this patient? So the local epidemiological bacterial isolate and resistance pattern are crucially important in determining first choice empirical therapy since a coverage for MRSA and gram-negative bacteria may be required. Meta-analysis comparing monotherapy, that is anti-pseudomonas cephalosporin like ceftazidime or cefepime, imipenem, meropenem or piperacillin tazobactam with combination therapy found equivalent efficacy. No specific indication for alternative therapy. So apart from standard treatment with broad spectrum antimicrobial agent, there are a number of situations in clinical practice that require specific regimen. The duration of treatment may vary and local antimicrobial guidelines should be followed in these circumstances. So we can, if the source of infection is a central IV catheter. So if the patient has IV catheter and catheter related infection, if we are suspecting that, then the blood culture must be taken from catheter and peripherally to measure the differential time of the time to positivity, which is the difference in time between the positivity of the result between catheter culture and peripheral blood culture. So if this differential time to positivity is more than 2 hours, then it is a highly sensitive and specific indicator of catheter-related bacteria. All cases of catheter-related infection in setting of febrile neutropenia require decision-making on choice and duration of IV antimicrobials and need for the catheter removal. When central line related infection is suspected and the patient is stable, catheter should not be removed without microbiological evidence of the infection. So in this case, we can start with glycopeptide like vancomycin. And this vancomycin should be administered through the line whenever possible to cover gram-positive organisms. Teicoplanin is useful alternative as it can be administered once daily as line block. Success in treating central line related infection without removing catheter depends on pathogen isolated in the blood culture. In central line related infection due to CNS, an attempt at preserving catheter can be made if patient is stable. Catheter retention does not impact on resolution of CNS bacteremia, but it's significant risk factor for recurrence in those patients in whom catheter was retained. So the removal of the line is indicated in the context of tunnel infection, pocket infection, that is implanted port cyst, persistent bacteremia despite adequate treatment, or typical mycobacterial infection and candida. With regard to line infection caused by Staphylococcus aureus, the literature is divided. So the desire to preserve line must be balanced against the risk of metastatic spread by bloodstream serum. And the recommendation should be to remove line if at all possible, while recognizing that with careful management, it might be possible to maintain it for a shorter period. Persistent fever and bacteremia, despite appropriate antibiotics, are indication for line. So if you are suspecting the source of infection are lungs, that is, if pneumonia in an outpatient is diagnosed either on clinical grounds or on the basis of radiological imaging, antibiotic cover may be extended to treat a typical organism like Legionella and Mycoplasma by adding macrolides or fluoroquinolone antibiotic to beta-lactam antibiotics. Consideration for infection with pneumocystis cerevisiae should be given in patient who presents with high respiratory rate or desaturated readily off oxygen or on minimal exertion. And the predisposing factors include prior corticosteroid therapy, use of immune suppressant after organ transplantation, and exposure to purine analog, as well as lack of reliable chemoprophylaxis with cotrams. In high risk patients with profound prolonged neutropenia lung infiltrate, early treatment with the mold and active antifungal agent is recommended. Now, in case of lung infiltrate, patient with the AML during remission during induction chemotherapy and those undergoing allogenic hematopoietic stem cell transplantation with prior conditioning chemotherapy, they are at risk of invasive fungal infection due to prolonged and profound neutropenia. Frequent assessment of initial response to antimicrobial antibacterial therapy is essential, and in the absence of prompt improvement, further investigations are warranted. If invasive aspergillus is suspected, the high-resolution chest computed tomography scan should be carried out on the same day, looking for the typical features such as nodule with halo sign and ground glass changes or galactomannan should be measured in the serum. If infiltrates is found, then bronchoalveolar lavage should be undertaken if possible. Advice from infectious disease specialist or clinical microbiology is recommended, and appropriate therapy against infection with fungus and pneumocystis cerevisiae should be instituted. And the choice of antifungal agent will depend upon the center, individual patient, and use of prior prophylactic therapy. Now, the therapy for presumed aspergillosis uh, could consist of either voriconazole or liposomal amphotericin B. These antifungals can be combined with echinocandins in unresponsive disease. A precise microbiological diagnosis is highly desirable in patients suspected of invasive fungal infection, as sensitivity to the various antifungal agent is variable among different species. High-dose cotrimazole is the treatment of choice for suspected pneumocystis infection. Now, vesicular lesion and suspected viral infection. After appropriate samples are taken, therapy with acyclovir should be initiated. Ganciclovir, that is, or fuscarnet, should be substituted only when there is a high suspicion of invasive cytomegalovirus infection. Suspected meningitis or encephalitis. Lumbar puncture before institution of antibiotic is mandatory in these rare cases. Bacterial meningitis should be treated with ceftazidime plus ampicillin or meropenem. Ceftazidime plus ampicillin combination is specifically to cover for Listeria monocytosis. Viral encephalitis is treated with high dose of acyclovir. Now, if we are suspecting the source of infection is cellulitis, then we should add the vancomycin, which brought the cover against the skin pathogen. Linezolid and daptomycin are emerging alternative treatment. Then, if the source of infection is intra-abdominal in the pelvis, then the clinical or microbiological evidence of intra-abdominal or pelvic sepsis exists, then metronidazole should be started. In case of diarrhea, we should assess for the Clostridium difficile infection. If we are suspecting it, then we should add oral vancomycin and metronidazole. In case of candidiasis, if the patient is at risk of disseminated candidiasis, there are those patients who are with the prolonged neutropenia, and especially those with the hematological malignancies undergoing myeloablative therapy. So this candidemia can be diagnosed on the blood culture. However, culture may take several hours, several days to become positive. Empirical initiation of antifungal therapy is recommended in patients whose fever failed to respond to broad spectrum antibiotic after 3 to 7 days of appropriate treatment. Now, CT scan of liver and spleen should be carried out before commencing anti-candida treatment, looking for typical changes. So the first line empirical treatment depend on what is known about the patient. The liposomal amphotericin B and echinocandin antifungal such as capsofungin are appropriate first line treatment if the patient has already been exposed to azole or if the patient is known to be colonized with non-albicans candida. Fluconazole can be given first line provided the patient is at low risk of invasive aspergillosis. Once begun, the antifungal treatment should be continued until neutropenia is resolved or for at least 14 days in patient with the demonstrated invasive candida infection. Specific needs for preventing other opportunity infection are required in patients with the hematological malignancies, namely those undergoing hematopoietic stem cell transplant. Now, daily follow-up and the assessment of the response. The frequency of clinical assessment is determined by severity but may require every 2 to 4 hours in cases needing resuscitation. So the daily assessment of the fever train, bone marrow, and renal function is important to identify infection and prevent complications. Now, assessment of the response. The response is defined by if the patient is afebrile and has ANC count of more than 500 at 48 hours and has a low risk and no cause of infection has been found, and if the patient is symptomatic and is on dual therapy, aminoglycoside may be discontinued. But when the cause is found, then continue appropriate specific therapy. If the patient is still febrile for 48 hours and if clinically stable, initial antimicrobacterial therapy should be continued. If patient is clinically unstable, antibacterial therapy should be rotated or broadened if clinical development justifies it. Assessing CRP in view of proceeding to imaging of chest and upper abdomen to exclude probable fungal yeast infection or abscess. After 4 to 6 hours, empirical initiation of antifungal therapy may be needed. Now, regarding duration of therapy, if ANC is more than 500 and the patient is asymptomatic and has been febrile for 48 hours, and if all blood cultures are negative, then the antibacterials can be discontinued. If ANC, if absolute neutrophil count is more less than 500 and the patient has suffered more complication and has been afebrile for 5 to 7 days, then antibacterial can be discontinued except in certain high risk cases with acute leukemia and following high dose chemotherapy when antibacterials are often continued for 10 days or until absolute neutrophil count is more than or equal to 500. Patient with persistent fever despite neutrophil recovery should be assessed by ID physician, clinical microbiologist, and antifungal therapy is considered. Now, this is the schematic representation of initial management of febrile neutropenia. If the temperature is more than 38 degrees Celsius and if absolute neutrophil count is more than 500, then and if there is a background history of any malignancy, and if you're suspecting febrile neutropenia, then a prompt assessment, vigorous resuscitation is needed, and calculate mass score so that we can categorize the patient into high risk and low risk. If the patient is high risk, immediately start with the broad spectrum antibacterial therapy, and if in case of low risk, in oral antibacterial therapy can be started. So after giving therapy, we need to review the patient at 48 hours. If the patient is febrile, if the neutrophil count are more than 500, and then categorize then we need to categorize the patient again into low risk and high risk. In the case of low risk, we can continue the oral antibacterial therapy, and we can also consider and if the patient is stable, we can consider early discharge. And if the patient falls into the low risk category and if he is on an IV antibacterial and antibiotics, then consider continuing therapy, and then later we can switch to the oral antibacterials. If the patient is at the high risk patient and the pathogen is not identified, then discontinue aminoglycosides. If pathogen is identified, then consider pathogen specific treatment. If pyrexia, if fever is, if even after 48 hours, if fever continues and the patient is stable, continue same therapy. And if the patient is deteriorating, then seek expert advice from ID physician and clinical microbiologist. Then regarding chemoprophylaxis, indications for primary prophylaxis of febrile neutropenia with granulocyte colony stimulating factor. Several meta-analysis indicates that primary prophylaxis with the granulocyte colony stimulating factor reduces the risk of febrile neutropenia by at least 50% in patients with solid tumor without significantly affecting tumor response or overall survival. So most guidelines recommended that granulocyte colony stimulating factor must be administered prophylactically if risk of the febrile neutropenia is more than 20% for all planned cycle of treatment. So the classification of the risk according to the type of chemotherapy has been published and updated. So for a patient with the intermediate risk, that is 10 to 20%, it is important to consider patient age, particularly any coexisting comorbidities. So this is the schematic representation of how to start this prophylactic chemotherapy. So if the febrile neutropenia risk is more than 20,000, then we need to start the prophylactic granulocyte colony stimulating factor. If this risk is 10 to 20%, that is intermediate, then we need to take the consideration of the other factors like age, if it is more than 65%, or any other comorbidities, and define the patient's overall febrile neutropenia risk for planned chemotherapy. If the overall febrile neutropenia risk is still more than 20,000, then better to start with prophylactic granulocyte colony stimulating factor. If it is less than 20%, then not needed. And if the overall risk of febrile neutropenia is less than 10%, then the no need of prophylactic treatment. So beside this approach, granulocyte colony stimulating factor can be considered in patients with reduced bone marrow reserve due to extensive radiotherapy or patients who are neutropenic in the context of HIV infection. The risk of febrile neutropenia is maximal during the first course, thus it makes sense to recommend primary prophylaxis for patients at high risk. So recent meta-analysis of randomized and controlled trial experience in real-world setting confirm outstanding success of primary prophylaxis with filgrastim and penfilgrastim. Secondary prophylaxis for that is with granulocyte colony stimulating factor for course of chemotherapy following course of febrile neutropenia is indicated. If dose reduction below threshold or delay of chemotherapy is not desirable, that is treatment with the curative intent. There are few complications associated with granulocyte colony stimulating factor administration, and the most common adverse effect is minor and moderate bone pain that can usually be handled with standard analgesics. Dose schedule. Now, regarding the dose schedule, route and the application of granulocyte colony stimulating factor and pegfilgrastim. Use 5 microgram per kg per day of granulocyte colony stimulating factors subcutaneously every 24 to 72 hours after last day of chemotherapy until sufficient stable and post postnatal absolute neutrophil count recovery, that is achieving target of neutrophil count of more than 1000 is not necessary. Then pegfilgrastim is injected as via subcut route as a single dose of either 100 microgram per kg or total dose of 6 mg is considered equally effective. The dose of ofilgrastim is 5 microgram per kg per day for 10 days. Now, the use of granulocyte colony stimulating factor in high-risk situation. The therapy of acute leukemia, autologous, and allogeneic stem cell transplantation lead to high risk of febrile neutropenia and potential lethal complication. And the incidence of this febrile neutropenia in high-risk situation is as follows. It is a common during autologous and allogenic peripheral blood stem cell transplantation, bone marrow transplantation, and during graft failure. The risk is 35 to 48% in AML cases at the diagnosis and 13 to 30% during ALL induction chemotherapy. Thank you, guys.